Hello everyone and welcome to this tongue-tie talk. Now, unlike my other recordings, which are more for mothers and parents preparing for their breastfeeding journey, this recording is more for people supporting mothers and babies on their breastfeeding journey. My name is Liana. If you don't know already, I am an IBCLC from Somerset West, which is in the eastern suburbs of the city of Cape Town in South Africa. Now, if you are like me, supporting breastfeeding babies, mothers, families, chances are you have come across a case where the adjustment made to the mother's position, the baby's latch, the baby's suckling, just doesn't seem to resolve the pain or discomfort the mother and or baby are experiencing. And perhaps you wondered if it was due to a tight tongue. Now, if you are an IBCLC, you should be able to know how to spot tongue tie and be able to tell families how this impacts lactation and be able to educate them about options they can explore for their child with their primary care provider. Just a quick disclaimer before we continue. Now, while you glance over the disclaimer, another disclaimer is that I am by no means an expert on tethered oral tissues. What is to follow is from my own research to inform myself better as an IBCLC in my own lactation practice and for the peer counseling course that I compiled for LaLage South Africa. Now, in the past, tongue-tie opinions and theories would have been discussed and debated within medical journals and professional communities. But now, everything is out there on social media, and it creates a lot of murky waters for worried parents to wade through. Also, unlike other congenital anomalies like a cleft lip, there is no easy box to check to say, yep, this is it, or nope, it's not there. And there is such a huge range and variability in how it presents. Even among researchers and clinicians, there is disagreement on the definition, what a tongue tie is, or what a lip tie is, or what a buccal-tie is, even how to identify it, and if it has an effect on breastfeeding, or teeth alignment, or speech, and what to do about it, if anything, and how to fix it. And also what interventions to recommend following revision. Now, this general lack of consensus in the area often leads to dismissive attitudes around tongue tie and a conservative approach to its management when clearly, in some cases, it is the underlying root cause of various issues. But whether the release of a tight frenulum in babies improves breastfeeding is not clear because too many of the symptoms of tongue tie overlap those of other breastfeeding difficulties, including things like protein intolerance, reflux, colic, neurological issues, etc. So not all babies with a restricted tongue function have a tongue tie. Birth trauma, developmental issues, low muscle tone, neurological issues, as mentioned, can impact the tongue function too. So a careful assessment is essential and a team approach is necessary. Now, I hope this talk will provide some insight because due to what I just said, parents may receive conflicting messages from different specialities. So hopefully by the end of this talk, you will have a better understanding of what tongue ties are, what's the big deal or consequences, the classification, how to spot it, alternative breastfeeding positioning to help compensate for a tight tongue, and we will also take a quick look at other causes and to snip or not. Right, so what are tongue ties? Now, if the answer is yes to any of these questions or observations, further investigation is warranted. So these questions are from part 2 of the frenotomy decision tool for breastfeeding dyads. Question 1. Does the baby have an inability to elevate the tongue at least midway with a wide open mouth? Meaning, does the tongue stay on the floor of the mouth when the baby cries or yawns? Or when the upper gum ridge is stimulated? Is the baby able to lift the tongue tip to the palate with a round or a square tongue, not a V or heart shape like the tongue in the picture? Now, a flat tongue or only the sides of the tongue lifting may indicate a tight frenulum or low tone. And just FYI, tongue tip elevation in premature babies indicate respiratory distress and an unreadiness to feed, not that they have wind. Next observation. The tongue can't cup or maintain suction on a finger or on the breast. Now, some babies are able to latch on a breast, yet the baby doesn't stay well latched, sorry for this judging word well, or the baby slides back to the nipple, or the seal breaks with a clicking sound during feeding, or one might also feel a humping rather than a cupping of the tongue when the baby is sucking on a finger. Next question. The baby has an inability to stick out the tongue past the gum line, or you see a bowl shape in the tongue when the baby tries to stick the tongue out, like this baby in the picture. A mother will often state that she noticed the baby doesn't stick the tongue out, or when the baby cries, the tongue edges elevate, but the center stays low, causing the tongue to form kind of a dimple or a bowl shape. Now, if you want to make a baby stick out their tongue, you can stimulate the lower gum ridge with the fingertip. And FYI, touching the future tooth-bearing surface of the lower gum ridge triggers reflexive biting. So a clue, if a young baby is biting while feeding, perhaps the tongue has a hard time extending over the bottom gums. Now, apparently a baby with low tone may stick their tongue out at rest, not having their lips closed, where we actually want to see the lips closed at rest. Another question is, there is diminished lateral movement of the tongue when the outer gum ridge is stimulated from the center to the side. Now, if a baby's tongue is being held down on the floor of the mouth, it will bunch or look thick as the baby tries to move the tongue from side to side. And then another question is, do you see white tongue but not white patches elsewhere? So this is an observation by many parents that the tongue midway back has a white coating, and this milk tongue is often confused with thrush, and often the mother and the baby have been treated for thrush without improvement. So what might be happening if the baby's tongue is tight? It can't elevate to rub against the palate to clean itself. So we think in utero the tongue presses against the palate and shapes it into a broad U shape, not like the baby's palate in the picture. That palate is high and not broad and not wide. So the palate might be high or narrow if the tongue is tight and couldn't press against the palate to smooth it out. Though the palate can also be high if the baby was premature or and didn't have enough time to smooth out the palate with the tongue in utero. Or perhaps the baby was breech, or perhaps there's some other congenital or genetic disorders resulting in a high palate. In any case, a high or narrow palate complicates breastfeeding. Here are some terms. So symptomatic ankyloglossia is when a physical examination is consistent with a restrictive frenulum and difficulty with feeding, whose difficulties are not improved with lactation support. Tethered oral tissues is a collective term, and it refers to restrictive tissue in the mouth that impacts how a person is able to use their mouth and includes tongue tie or ankyloglossia, lip tie, and cheek ties or buccal-ties. And here are just some terms for surgical procedures to release a frenulum, though I will probably just refer to it as a snip. Now, the presence of a piece of tissue or frenulum under the tongue or lips or around the cheeks does not mean someone is tied. So just because you can see it doesn't mean it will affect breastfeeding. Similarly, just because you can't see it doesn't mean it's not going to affect breastfeeding. A true tie affects the function of a body. So its appearance is not as important as how it functions and how comfortable and effective the baby can feed. Now, some babies will indeed benefit from a frenotomy or a snip, and others who have multifactorial causes or feeding difficulty may have minimal or no benefit from a procedure. So always first make sure that it is not the mother's position or the baby's position or the baby's latch or the baby's suckling that needs adjustment, because it may be as simple as that. Okay, so the frenulum under the tongue stabilizes the tongue and it determines the tongue's range of motion. So the placement of the frenulum won't change naturally. And there's also no data that a frenulum lengthens over time. However, some people have stretchier frenula than others. And an interesting observation from research is that because the tissue at the base of the tongue contains the tongue muscle, this muscle may lengthen with use and the baby's feeding ability may improve with time. Now, when the tongue moves inadequately, the baby may not be able to maintain an optimal seal on the breast and often cannot suck and breathe in a coordinated, efficient manner. The work of breastfeeding may increase, putting the baby at risk for limited intake and fatigue. And apart from hurting the mother, the ineffective feeding doesn't stimulate the breast enough for ongoing milk production. Tremors or trembling or shaking of the tongue and the lower jaw after feeding can occur due to fatigue in a baby who uses compensatory sucking strategies, meaning they are trying hard to compensate for something else not working as it should. And I think it's a reliable sign baby is working too hard to feed. Now, oral anatomy and motor functions should be assessed when tremors occur and growth should be followed closely. So how is the lingual frenulum formed? Research by Nikki Miles shows the sublingual frenulum under the tongue is a fold of tissue that arises as the tongue lifts and places tension on the floor of the mouth. So when the tongue is elevated, a midline fold is formed. Sometimes the fold contains only oral mucosa and it will appear almost see-through and it will look something like this. Sometimes the fold contains oral mucosa and floor of the mouth fascia, and it will look a little thicker, something like this. And just interesting, if you don't know this already, the tongue fascia connects all the way from the tongue through the body systems right down to the toe. Sometimes, this is a picture on the right, when the tongue is lifted, the fold may contain mucosal layer, fascia, and tongue muscle, and look like the picture on the right. That is also called a submucosal tie. Okay, so a direct correlation between what the frenulum looks like and if it has an impact on how the tongue moves has not yet been established. So the diagnosis of the tongue tie remains subjective. Let me just repeat this. The diagnosis of a tongue tie remains subjective. This means get a second opinion. It takes much more than a hasty glance over the baby's mouth to ascertain if the tongue is restricted or not. And the diagnosis of a tongue tie in the context of breastfeeding involves a combination of two elements: examination of the baby's tongue and observing the baby breastfeed. Now, how many babies are being diagnosed as having a tongue tie or dismissed that it is an issue, but the person making the diagnosis didn't even bother to observe the baby breastfeed? Now, very often the person examining the baby's tongue and observing the baby breastfeed is someone who is not qualified to diagnose. Now, I'm sure you all know this, but pain during breastfeeding means something is wrong. So when a mother says that they are in pain, we need to hear them. Just telling a mother, "Ach, it should get better with time," is not an acceptable response. And some mothers think pain means that they are doing something wrong, and we need to communicate that it is not their fault. We should let the mother know that we will work with them to figure out what is causing their pain so that breastfeeding will stop hurting. Some lactation experts feel it might be that practitioners ignoring mother's pain has led to much of what is happening on social media. Also, listen to the mother saying that her baby is on the breast all the time and never seems satisfied. Often these struggles are minimized and mothers are told to supplement. Now, in some cases, supplementation, and of course, ideally the mother's own milk, may be necessary in the short term, since the baby may have been struggling and no one picked it up until there was a crisis. Anyway, a baby on the breast all the time should be evaluated, and a tongue tie is one possible reason, and it is a direct threat to the mother's milk supply. Okay, so if the mother thinks that her baby has a tight frenulum and she is in pain during feeding and or her baby is gaining suboptimally, first make sure that it is not her position, the baby's latch, the baby's suckling that needs adjustment. Sometimes the position of the baby's head during a feed negatively influences the tongue position. For example, like the baby in the picture. When the baby's chin is more on their chest, away from the breast, with their head tilted to the front and the nose buried in the breast, the baby can't open their mouth wide, they can't stick out their tongue, they can't get enough breast tissue into the mouth, and then they can't latch deep enough. So we check positioning and latch first because any issues, whether it is with the breast, like engorgement or mastitis, or with the nipple, like nipple pain, or uh, cracks or blisters, or the mother's milk supply, or the baby's weight, or the baby's behavior, the very first thing that we can do is look at positioning and latch, because again, more often than not, this is the cause of the problem. So remember, it's not what the tongue looks like, but how the tongue functions that is important. Although all of the things that I have mentioned here could also be caused by baby's tight frenulum. Okay, so what is the big deal or consequences of a tight tongue? Now, this is a list of tethered oral tissue questions related to the baby. I compiled it from a variety of sources, though please note that many of these questions also point to suboptimal breastfeeding techniques and management, which is a complex issue. And every mother-baby pair with painful or ineffective feeding should have a complete breastfeeding assessment before any other treatment is offered. So this list can provide a clue to tethered oral tissues and also show some consequences or possible consequences, even before one takes a closer look at the tongue and breastfeeding. Now, this list is available, so please just contact me if you need this or want this. And just FYI, not everything on this TOT list will necessarily be present. And this list is not for diagnosing a tongue tie, it's rather a clue to investigate further. So some tongue-tied babies breastfeed without difficulty. Now, research shows about half of babies diagnosed with tongue tie or ankyloglossia can breastfeed without difficulty. Remember, breastfeeding involves two people, a mother and the baby. So sometimes the mother and baby's anatomy are such that they just fit perfectly, and the baby with a tight tongue can still get enough milk to grow well and not hurt the mother at all. While other babies cause their mother pain, either because of continuous irritation by the tight frenulum, or the baby slides back onto the nipple and can't maintain a deep latch. Now, nipples often look pinched after feeding, wedge-shaped, similar to a new lipstick. And this pinching may also restrict blood flow to the nipple during feeds, leaving a white, like white in color after feeds. Or blanching, and once the baby comes off the breast, the blood starts to flow back, and this can cause a throbbing pain or a burning or stabbing pains deep into the breast tissue. Some babies don't get enough milk. There might be a chewing-like motion while breastfeeding, or there may be lots of sucking but not a lot of swallowing, so the baby is not transferring milk. Now, some have a difficult time staying attached to the breast. There may be a clicking sound like with feeding as the tongue can't maintain a seal. Some babies fall asleep at the breast before the end of feeds. Some feed frequently or for a very long time and still gain suboptimally. Some babies have a difficult time feeding, breathing, and swallowing in a coordinated manner, and they are very unhappy during and after the feed. They are coughing on the milk, dribbling during feeds. Now, although half of babies diagnosed with a tongue tie or ankyloglossia breastfeed without difficulty, there is sufficient data from several studies that a tongue tie can cause breastfeeding problems because some babies with a tight tongue just cannot get a deep enough latch and cannot exercise the full range of tongue motions necessary to breastfeed effectively and comfortably. Also, this limitation in the mobility or strength of the tongue requires the baby to use compensatory activities like jaw clenching or lip retraction, tongue thrusting or jaw dropping to achieve milk transfer or to feed, which often damages the mother's nipple. Now, for the long-term consequences of an untreated tight tongue on eating solids with comfort, proper teeth alignment, and other dental pathologies. Also, difficulty licking ice cream, kissing, playing wind instruments, issues with speech, difficulty with articulation, breathing and sleep problems, even concentration and focus, probably more things. It's difficult to say what the long-term consequences will be because each baby is unique and a lot of the claims are not evidence-based. So as mentioned, many professionals who work with babies believe that the position of the tongue at rest and while feeding shapes structures in the mouth, particularly the hard palate, which may further impact speech and teeth. But as mentioned, additional research is needed in this area. Now, some of the symptoms of tongue tie overlap or are similar to those of a high palate. So it can make it challenging to determine which symptoms are due to the tie and which are due to the baby's palate. But if the baby is born full term and was mostly head down in the last weeks of pregnancy, a high palate for me is one of the first signs to investigate the tongue function further. And high palates are just another complication to an already complex situation for tongue-tied babies. And even when the ties are resolved, problems with feeding and reflux and congestion and open mouth breathing may persist. Craniosacral therapy may be beneficial for babies with a high palate, but the baby also may need work done by an occupational therapist and a speech-language pathologist. Luckily, according to the experts, we can enact change on the palate by changing the inputs into the palate as the bone grows. So breastfeeding has a positive effect on shaping the palate. This is a list of tethered oral tissue questions related to the mother. And again, not everything on this list needs to be, will necessarily be present. So, mother's nipples may look misshapen or blanched after feeding. The nipples may be sore or cracked, blisters, bleeding, bruised. The mother might have already had mastitis or blocked ducts. Maybe she's struggling with low milk supply and exhaustion from this frequent and constant feeding. And just FYI, if the baby cannot handle the flow, many mothers believe that they have an oversupply or an overactive oxytocin or letdown reflex, but it's often not because the flow is too rapid, it's because the baby's latch could be more effective. Okay, let's look at classification. Now, there are many different tongue tie classifications. Ties are generally divided into two main groups, anterior and posterior, and this is simply a way of describing what we can see. So the anterior tie is obviously more towards the front, and the posterior tie or tongue restriction is hidden under the mucosal lining of the mouth floor. Now the problem with this one, with the word posterior, is that those that are unfamiliar with the classification may mistakenly think that the tongue is tied or the tongue tie is at the back of the throat, but the lingual frenulum doesn't connect to the posterior tongue. The suggestion is that the term posterior tie should be discontinued. The better descriptive term would be submucosal or hidden tie or mid-tongue restriction. Most practitioners use classifications where the tongue is given a grade of 1, 2, 3, or 4. And classification systems, again, is merely a description of where the tie attaches to the tongue. So class 4 babies could have severe breastfeeding problems and class 1 babies could feed normally and vice versa. So I have said this already, it's not necessarily how the tongue looks, but how the tongue functions that is important and for breastfeeding. And to this end, numerous tools for assessing the severity of ankyloglossia have been developed. So some experts feel that all babies should be screened for tongue tie and other oral issues within the first week of birth. Newborn babies are screened during the routine newborn assessment shortly after birth for a variety of abnormalities like congenital hip dysplasia and hard murmurs and cleft palates. However, this check does not include assessment for tongue tie. And even if the parent specifically asks for the newborn to be checked for tongue tie, it is highly unlikely that the person doing the check will not have had would have had a specific training in tongue assessment and will therefore not be able to confirm or with any certainty whether the tongue tie is present or not. I like to use these two assessment tools, and we will have a look at them a little bit closer in a bit. I just want to point out that systematic clinical observation and assessment of a mother-baby pair consists of several areas of evaluation. So it's not just looking at the tongue. So this is why we need trained people assessing tongue function and breastfeeding, etc., and see if perhaps something else is going on. Okay, let's have a look at how to spot it, keeping our systematic clinical observation and assessment of a mother-baby pair in mind. So a frenulum may be thin and stretchy, or it may be short and thick. It's difficult to tell if it will pose a problem for breastfeeding or not pose a problem just by looking at it. And I have said this before, but let me just repeat this. It's difficult to tell if a tight frenulum will pose a problem for breastfeeding or not pose a problem just by looking at it. We have to ask, does the frenulum interfere with the baby's ability to breastfeed comfortably and remove milk well? And have other possible causes of a tight frenulum and feeding difficulty been ruled out? A mother's breast comes in many different sizes and shapes, as can her baby's mouth. The crucial factor is how the two function together. And I know I've mentioned this several times already, so hopefully you get it by now. Now, the picture in the middle and on the left are ties with anterior attachment, so the tie is close to the tongue tip. Typically, it causes a heart-shaped indent appearance to the tongue tip at rest or with examination. Tongue ties with a more posterior attachment, like the picture on the right, can be more difficult to visualize, but it can still interfere with breastfeeding if it affects tongue mobility and range of motion. So to try and visualize this frenulum, you can use your left and right index fingers and reach under the baby's tongue to lift the lateral margins of the tongue. The baby's head needs to be towards you, so you'll be coming from behind. Okay, now as mentioned, assessment for a tongue tie cannot be done just by looking at it. A physical digital assessment involves observing how the baby uses their tongue and placing a gloved finger in the baby's mouth, assessing for lift, lateralization, extension, etc. Also looking at the shape of the tongue tip, where it attaches to the floor of the mouth and where it attaches to the underside of the tongue, etc. And just to clarify, I'm not teaching you how to do it. Assessment requires training and skill. I'm merely telling you what I do. And what is to follow is appearance and function items all mixed up, since it's easy and quick for me to do an assessment in this order and then score it on a formal structured assessment tool to objectively evaluate the severity of tongue restriction and to be able to discuss options and further management with parents, and then refer to an ENT or a dentist for a diagnosis and the decision to treat. So the babies or the baby is either on the assessor's lap or on a flat surface such as a table. And while assessing a tongue, tell parents what the pointers are that we are looking for, and always ask both the mother and the baby's permission before touching the baby. Now, depending on the baby's interest in cooperating on that day of the assessment, just need to mention that some people feel tongue assessment can change dramatically from moment to moment because a baby uses their tongue muscles differently under different circumstances, depending on the baby's tone and the baby's state, and whether the baby is wakeful or sleepy or hungry or satisfied, or even how well nourished or underweight the baby is. Anyway, let's look at some of the most common characteristics included in most tools assessing for a tight tongue. Now, bear with me. Many tools describe and assign values to the appearance and the function of the tongue. So, as the baby cries or yawns or tries to lift or extend the tongue, one will inspect the front edge of the tongue, and we want to see a round or a square tongue. A tongue that is notched with a slight cleft in the tip, or a heart-shaped tongue when the baby tries to stick out the tongue, could be a clue of a tight tongue. Like the baby in the picture who has a slight cleft in the tip of the tongue. How far the tip of the tongue can lift is another characteristic to look for. So do it while you are looking at the tongue's appearance. So one tool calls it tongue posture during crying. Tongue elevation is key to good milk transfer and helps shape the palate. So tongue elevation is easy to assess when the baby is crying, but it can also be noted when the finger is removed from the baby's mouth after assessment for some of the other characteristics. Now, I peek at the tongue elevation and appearance if the baby is crying while the parents undress them for the weigh-in. So with the mouth wide open, we want to see if a baby can lift the tongue up to the roof of the mouth, like the baby in the picture. All the way up is perfect. Halfway is apparently enough for most babies to be able to breastfeed. But most tongue-tied babies can only lift their tongues when their mouths are mostly closed, meaning limited elevation, suggesting possible tight tongue. Now, in tongue-tied babies with a wide open mouth, the tongue often stays quite flat on the floor of the mouth, and mothers will often say that when the baby cries, the tongue edges elevate and the center stays low, as mentioned, forming a dimple or bowl shape, like the picture at the bottom on the right side of the slide. And other mothers notice a V shape or a heart shape in the tip. A characteristic most often mentioned in various tools is if the baby is able to stick their tongue out past the bottom gums or lips. Now we want to see the tongue come out flat over the lips without dipping or pointing down. If a baby can only stick the tongue out when the mouth is closed, that can indicate a tie further back. So this extension of the tongue is measured by eliciting the tongue extrusion reflex. Extension keeps the tongue over the gum line for the latch and obviously for mom's comfort. So to see if the baby can stick out their tongue, one would touch baby's lips, and then the baby will usually open the mouth, and then one can touch the front of the lower gums with the tongue tip, or brush the lower lip down towards the chin, or gently tap on the tongue tip, or lightly rub the bottom gums to elicit the tongue protrusion. So this makes the baby stick the tongue out. So the baby in the picture could not stick out the tongue over the lower lip or over the lower gums, which is another clue of a tight tongue. So just to mention, it's a common fallacy that a baby can't be tied or problematic if the tongue can extend over the lower gum line. The tongue is capable of numerous different movements, and normal movement in one direction doesn't guarantee normal movement in all directions. So the motion during breastfeeding is very specific. The primary movement is up, not out. Next, what most tools call tongue lateralization. So we want to see that the tongue is moving from side to side without jaw shifting, and it's done by eliciting the transverse tongue reflex. So when you run your finger along baby's lower gum ridge and brush the lateral edge of the tongue with your finger, the tongue will move to the side where it receives touch. It's like the tongue is trying to follow the finger. So the tongue sweeps side to side. Lateralization helps maintain a latch. It removes a bolus of milk, or moves the bolus of milk. And later when eating solids, it helps move food right and left during chewing. Now we want to see the tongue completely following stimulation without twisting. If the tongue twists, it suggests possible sign of a tight tongue, and it might look like a truck falling over. So I usually start my finger in the middle of the lower gum rim and trace it, say, to the right side and back to the middle and back to the right side and see how the baby's tongue follows my finger. And then I trace the lower gums to the other side and back to the middle and back to the side and see how the baby's tongue follows my finger. Another characteristic to note is the attachment of the frenulum, either towards the mouth floor or close to the inside of the lower gums. So it should insert nearer to the center or the middle of the lower gums, or into the tongue muscle on the floor of the mouth, or well below the gum ridge. I usually I use my gloved finger to feel under the baby's tongue on the floor of the mouth, sweeping from one side to the other. And if the frenulum is attached to the gum rim, you will have to kind of jump over it. And then you can note where it is attached, if it's to the floor of the mouth or to the gum rim. Now, most babies, I feel it lower on the gum rim towards the mouth floor. And the baby in the picture, the frenulum is attached to the gum ridge, which is another obvious clue of a tight tongue. Another characteristic looked at is the frenulum length. So the length of the frenulum is determined by noting its approximate length in centimeters as the tongue is lifted. So just after I've gently swept my gloved finger under the baby's tongue to feel the frenulum attachment, I turn my finger sideways to feel the length of the frenulum. And when you feel the frenulum and it feels short, like less than a centimeter, it could be a clue of a tight tongue, like the baby in this picture. And one can also feel for frenulum elasticity while feeling for length. Now, according to an expert, at first elasticity might be subjective until you can see the difference between a frenulum that is just mucosa versus the one that has the fascia layer underneath in the fold, or the fascia layer plus tongue muscle within the fold. So the last two will be less elastic. Fascia also has varying levels of elastic fibers in it. So when you lift the tongue, with experience, you will begin to feel the resistance when the tissue is less elastic. And visualizing the tissue helps to reduce the subjectivity of elasticity. Obviously, we want the frenulum to be elastic. Most tools also look at the attachment of the frenulum under the tongue. So attachment should be approximately 1 centimeter posterior to the tongue tip. So right after feeling for length and elasticity, I turn my finger with the soft part of my index finger under the tongue, and I feel from where the frenulum is attached under the tongue to the tongue tip. Now, research has found that the average length from the tongue tip to where the lingual frenulum inserts in the base of the tongue is between 9 and 10 millimeters in newborns. And the shorter the distance from where it is attached to the tongue tip, the more problems will be associated, such as difficulty with breastfeeding, hurting the mother, difficulties with sucking, etc. Some assessment tools also look at what they call spread of the anterior tongue. So the spread is determined by first eliciting the rooting reflex just before cupping by tickling the upper and lower lips and looking for even thinning of the anterior tongue. And then lastly is tongue cupping of the finger and how the baby is using their tongue. I gently place my gloved finger in the baby's mouth with the pad of my finger against the roof of the mouth. My nail would be down on the baby's tongue. And this elicits sealing and suckling or sucking with an anterior-posterior peristaltic rhythmic movement of the tongue. And cupping is felt on the finger as the baby sucks on it, and it can also be visualized by pulling the corner of the baby's mouth aside to see the tongue seal. And a firm cup enables the tongue to seal adequately around the breast, and we also want to feel the entire tongue having a nice firm cup. And the peristalsis is felt as a kind of a backward wave-like motion of the tongue during sucking, and it should originate at the tip of the tongue. Partial movement or movement originating posterior to the tip, or no movement or reverse peristalsis may indicate that something is amiss. And cupping and peristalsis helps to form a proper seal. It helps bolus control, it reduces air intake, etc. And some babies are able to latch, yet the baby doesn't stay well latched, or slides back to the nipple, or the seal breaks during feeding. And this sound of the vacuum breaking is heard as a clicking noise while feeding. One tool calls this snapback, Obviously, we don't want to hear any snapback or clicking. Frequent clicking or clicking with each suck means investigate further. Okay, now that we have an idea of the characteristics of what most tools look for, let's look at two formal structured assessment tools. The first one is the tongue tie and breastfed babies or TABI assessment tool. The TABI only assesses tongue structure and function. It doesn't investigate the impact on breastfeeding, but this tool is quick to use. It is simple to score. Or a simple score of the severity of tongue tie. And TABI is intended to be used as a part of an initial assessment of a perceived tongue tie. So TABI provides a visual aid to be clear about crucial features of tongue tie. It looks at the appearance of the tongue tip. It looks at the attachment of the frenulum. It looks at the mobility of the tongue, its lift and protrusion. And it asks 4 questions. It asks, what does the tongue tip look like? So this is usually the most obvious and most likely to be noted by parents, though a notch in the tip of the tongue may only be noted when the baby lifts the tongue. Another question is, where is it fixed to the gums or the gum? With some training and experience, this can be assessed visually. If it's difficult to see, one can gently use an index finger to feel where the frenulum is attached. Another question is, how high can the tongue lift while the mouth is wide open? One would need awareness of normal tongue lift in babies. The tongue may curl back when restricted, so it appears to lift, but the lift is most easily viewed when the baby is awake and crying. And the last question is, how far can the tongue stick out? So the easiest way to assess protrusion is to watch the baby as they latch to the breast. Are they able to bring the tongue out to latch? A parent can also brush the lower lip downwards towards the chin, and this would elicit tongue protrusion. So basically, one will look at the picture and baby's tongue and then assign a score and then add it up and note the suggested meaning. A score of 8 indicates normal tongue function, 6 or 7 is considered as borderline, and the suggestion is wait and see, with support for breastfeeding, positioning and attachment. And then 5 or below suggests that there is impairment of tongue function, and this may or may not be having an effect on breastfeeding. So depending on the score, the parents will go to the appropriate care provider for a diagnosis and further treatment. And this tool is freely available on the internet. So just to mention, if the decision is to not treat a tie and only follow up, that wait and see, make sure that the baby is followed up with a lactation consultant every week. Because, and I'll probably mention this again, late intervention could result in ineffective sucking patterns, causing low milk supply and low weight gain. Because some babies rely on an ample milk supply and a strong milk ejection, and they gain weight well in the early days and weeks. And this may change as the baby gets older and the milk supply establishes, and the baby cannot really generate enough or a sufficient vacuum to maintain milk production and or get what they need to continue to grow as expected. Okay, let's take a quick look at the Hazel-Baker assessment tool for lingual frenulum function, and this tool is a little bit more involved and it should be used as part of a detailed feeding assessment. So the Hazel-Baker assessment tool has undergone validity and reliability testing, and it assesses 5 visual characteristics or appearance of the lingual frenulum and 7 functional movements of the tongue. So each of these 12 items has 3 sub-items with a number of 1, 2, 1 or 2 assigned to each. So normal characteristics gets assigned a 2, and if there's significant, if it's significantly abnormal, it gets assigned a 0. And the higher the score, the closer to normal the baby's tongue function and appearance is. And 14 would be a perfect function score, regardless of appearance items, and surgical treatment is not recommended. 11 is an acceptable function score only if appearance item score is more or equal to 8. and less than 11 for function scores indicates function impairment. So if the tool is used correctly, no baby will score low on appearance and perfect on function. So this Hazelbaker assessment tool, like the Tabby tool, is freely available on the internet. But if you want to learn how to use it, you can go to hazelbakerinstitute.com. So here is an example of me using the Tabby as a quick screening tool, although this obviously looks like a tie. But if you are not qualified to diagnose, neither you nor me can make a diagnosis, but we can say what we see. So this baby's mother contacted me on day 10 saying baby latches easily but stays hungry. So obviously their anatomy just fit perfectly. Now I count 1 point and according to the tool 5 or below suggests impairment of tongue function. When I use the Hazelbaker assessment tool on the same baby, the assigned value and then assigned values as indicated on the score sheet, it was 1 point for appearance items and 1 point for function, which means frenotomy according to the assessment tool deemed necessary. And yes, the ENT snipped it and the baby breastfed for several years. Here is another example of me using the Tabby as a quick screening tool. Now this baby never hurt the mother, but the baby was uncomfortable. The baby wasn't gaining as expected, and the mother noticed the clicking sound every now and then. So this looks like a hidden or submucosal or mid-tongue restriction, whatever you want to call it. But if you are not qualified to diagnose, again, neither you nor me can make a diagnosis, though we can say what we see. So using a formal assessment tool here helps to objectively evaluate if there are tongue restrictions impact the ability to function normally. And also, again, it helps with discussing options and further management with parents, since the problem here could very well be due to positioning and latch and breastfeeding management. So I counted 6 points, and according to the tool, 6 or 7 is considered borderline, and a wait and see approach is suggested. And just FYI, you can't see it clearly in the picture, but the baby's mid-tongue dimpled when it was assessed. When I use the Hazelbaker assessment tool on the same baby, since the Tabby doesn't fully address functional assessment, the score was 10 for appearance items and 7 for function. And the assessment tool says less than 11 for function scores indicates function is impaired. So we tried management here first, adjusted the mother's position and the baby's position. Mother in a more laid back position, baby more tummy down, mother supporting her breast from underneath for a deeper latch and more effective feeding. I'll explain this just now. We also referred them for body work for the baby, and by 2-3 months the mother stopped with the breast support under her baby's jaw, and the mother and baby had a great breastfeeding journey. Now, I don't know if this lowish function scores were due to tightness somewhere else, which relaxed with manual therapy, or if it was the tongue muscle that lengthened with use and the baby's feeding ability improved, or if it was because the baby was a little underweight, conserving energy, limiting tongue use, kind of just drinking at a fountain, only moving slightly and only with high milk flow, making it appear the baby had restricted tongue mobility. And once the weight and energy caught up, the baby used their tongue just fine. And this apparently hidden tongue magically disappeared. So this is why we start with positioning and latch and refer if breastfeeding support alone doesn't help. So let's look at compensatory techniques, or in other words, alternative positioning to compensate. Right, so as mentioned earlier, if you think the baby has a tight frenulum and the mother is in pain during feeding, first make sure that it's not her position, the baby's latch, the baby's suckling that needs adjustment. Often just positioning the baby more tummy down with the mother being more laid back does the trick. If that doesn't work, another technique to compensate is to support the breast from underneath to help the baby get a deeper latch. It is based on kind of a medieval way um, of breastfeeding, looking at paintings of mothers and babies from previous centuries. Myrthe von Lonkhuizen developed what she called the Concord hold because this hold lifts the breast but angles the nipple down like the nose of a Concorde aircraft. And her infographic is freely available on the internet. So when a mother supports her breast where the baby's lower jaw touches her breast, it also helps lift the breast over the jaw. And the mother's arm will also pull the baby's lower body a little closer, allowing the baby's head to tilt back gently. I often explain to mothers to start with her fingers between her breasts on her chest and to slide her fingers on her chest around her breast to below where baby's jaw is, and then start lifting the breast until her nipple feels more comfortable. Now, how far to lift differs between mother and baby pairs because we are all individual and with unique anatomy, etc. So some mothers lift their breast so it forms a straight line with the baby's jaw, and this lift may change the position of the nipple past the deep palate more towards the comfort zone. And apart from not experiencing nipple pain anymore, mothers often note that their baby's suckling also seems stronger. Right, let's look at other causes. So if there are breastfeeding problems early after birth, tight frenulum may be a contributor to baby's feeding problems, but there are many conditions that may impact the function of the tongue by placing tension on the frenulum, making it appear restrictive. Maybe the position in utero could be a cause. Maybe it was the birth itself or instrumental birth, like a forceps or a vacuum, or conditions like the Pierre-Robin sequence might make the frenulum appear tight, and dividing the frenulum when the real reason for sucking problems is a short jaw or muscle tightness in the face or neck will not help and can make the problems worse. So we want to see symmetry. So when the baby's lying on their back with their head straight, we want to see the eyebrows in line as well as the cheeks and the ears and the lips. We want to see jaw alignment, tongue symmetry. We want to see the shoulders, nipples at the same level or in line, etc. Any asymmetrical appearance may indicate the need for referral, perhaps bodywork. So when the baby yawns, is the mouth symmetric or asymmetric? When you notice any asymmetric movements, it could indicate the reason for feeding problems. The baby in the slide on the left is probably doing a cute, oh, I'm so cute, head tilt. I can't say whether the baby has tight neck muscles on the right side. And with the asymmetric yawning baby in the picture in the middle, it seems like there's a little sucking blister on the top lip. Sucking blisters are usually a telltale sign of latch problems. So babies may have two-toned lips or swollen lips after the latch, sometimes blisters. Look at the picture on the right bottom. All these indicate latch difficulty. These babies tend to hold onto the breast or worse the nipple with their gums and lips if the tongue and or cheeks aren't keeping up their end of the deal. And mothers may report a gumming or biting sensation. The lips muscles naturally start working harder and it then creates friction on the breast, and that friction is what causes the blisters. So maybe the least invasive and first place to start after basic lactation assistance, optimizing the positioning and latch, and a thorough lactation consultation, and the baby is still unable to latch or feed effectively or causing the mother significant pain, would be some form of body work. Though not all authors agree, since these treatments are not well studied. But this musculoskeletal infant breastfeeding assessment questionnaire was introduced as a method of measuring suboptimal infant feeding without measuring latch, and created a method for practitioners to gain inter and intrapersonal information regarding breastfeeding beyond lactation consultants. So it is also an outcome-based measure, or assessing outcome of manual therapy. Though I think it will give a mother a clue to perhaps take her baby for body work. And this tool is also freely available on the internet. So bodywork is manual therapy for the body. It's not going to stretch the frenulum. Body workers locate areas in the body impacted by restriction, and then they mobilize these areas. So it could be done, work done by an infant chiropractor, physiotherapist, osteopath, cranial sacral therapy, myofascial, fascial release, or a combination of these. And getting bodywork done before a procedure to release a tie can also help minimize things ahead of time and ensure a procedure isn't done unnecessarily. But remember, manual therapy is helpful in reducing muscle tension. It will not get rid of the actual tie. Right, so to snip or not. So as you know by now, major controversy exists around when and how the frenulum is determined to be limiting movements and when that limitation is sufficient to warrant surgical intervention. And as mentioned before, the problem is decision-making around frenotomy remains subjective to the practitioner's bias. So the goal of treatment should be to improve function, and non-surgical options should be considered for all before proceeding to or considering surgical treatment. And then if non-surgical management fails, surgical treatment can be explored, such as laser or therapy or scissor release. Now, there are no comparative data on the use of laser versus clipping for frenotomy in babies younger than 6 months, although fans agree or argue that laser is more exact and provides better hemostasis than standard frenotomy. But the truth of the matter is the skill of the practitioner wielding the tool is more important than which tool is used. So this is just something for mothers to take part in the decision-making process. She can use her brain to make a decision that is right for her and her baby. So when talking with her healthcare provider, she can ask, what are the benefits of the decision? What are the risks associated with the decision? What are the alternatives? How do I feel? What does my gut say? And what if I decide to do nothing, wait and see? What happens then? What happens next? If parents are unsure when to consider treatment, they could consider treatment when a functional assessment indicates the necessity, when all aspects of feeding issues have been addressed, if the baby is happy with intraoral touch, if the baby and the parents are able to tolerate some stress, if they have capacity for the work ahead, if the clinician is confident in the timing of treatment, and if treatment is in line with the parental goals. Treatment should be delayed if a baby is too compromised, if there are other priority health concerns, or if the baby is non-latching or feeding progress has not happened yet. A snip is not always going to magically make a baby latch. So the surgical release of a classic tongue tie can be an effective intervention if maternal nipple pain and or poor milk transfer, milk supply issues, baby's weight gain issues, etc., cannot be addressed through conservative measures and physical examination is consistent with a restrictive frenulum. Although many experienced practitioners say just cutting what you can see is not enough to release the frenulum, one might need to go deeper. But deep oral incisions or tissue incisions for a hidden tie or mid-tongue restriction beyond the classic tongue tie have unique hazards and require high level of skill and attention to avoid potential risks of bleeding and tissue damage. And it's not possible to visualize all the branches of the lingual nerve, so there's a risk of nerve injury and resulting pins and needles feeling or numbness of the tongue, and babies are unable to report any loss of tongue sensation. So it doesn't matter who snips or lasers the tie, if it's the ped or the ENT or the dentist. Choose professionals who knows what they are doing and who is gentle while doing it. And then a good practitioner will always refer the mother-baby pair back to a lactation consultant for further breastfeeding assistance. So just FYI, the presence of an upper lip frenulum connecting the underside of the top lip to the gums is normal in a baby, and it has an unclear relationship to breastfeeding difficulties. So confusingly, many people may use lip tie to refer to the normal presence of the membrane in that location. So the term lip tie describes a membrane that restricts the normal movement of the top lip, as with the membrane under the tongue. Just because there is a frenulum under the lip doesn't mean it's going to be a problem. So during a feed, the lower lip may be turned out a bit, but the upper lip is neutral, just resting on the breast and just helping to create a seal. So given the role of the top lip during breastfeeding, just to rest on the breast and create a seal, the position of the frenulum under the top lip is unlikely to be a cause of breastfeeding problems for a majority of mothers and babies. So the top lip doesn't need to gape away from the gums or flare out like the lips of a fish. In fact, a flanged or flipped up upper lip during feeding may be a sign of a shallow latch or the baby overshooting the breast. So there are several reasons to explain why a baby's top lip might curl in or overly grip the breast or lose suction or be moving excessively and seem to cause pain. And any of these could be confused with a lip tie. And some experts say that the top lip that folds in is a tongue tie symptom because the baby is overcompensating, like when you purse your lips to suck on a straw. Either way, overuse of a top lip produces a large sucking blister on the top lip. So before a mother diagnoses her own baby with a lip tie, perhaps she can have positioning and latch checked by someone trained in breastfeeding support. And just as a side note, consensus are that surgery to release buccal frenulum or cheek ties should not be performed. And again, just because you can feel them doesn't mean that they need to be released. Right, so what about post-snip treatment? Evidence is lacking to support prescribing post-procedural manual manipulation or stretching after frenotomy at or near the cut area to open the wound or to prevent reattachment or contraction of the scar tissue. But prescribing this will depend on the practitioner. Many do feel that specific oral motor exercises, such as resistance training with a finger, may be appropriate, depending on the presentation of symptoms and the baby's response to the exercises. And people trained in body work can help with this. A disorganized suck or a weak sucking patterns can also benefit from these exercises. And these exercises are often started before a snip as well. So if the practitioner says that a snip is needed and the parents decide not to go through with it, maybe because the mother isn't in pain and the baby is gaining weight right now. As mentioned before, mothers need to keep in touch with a lactation consultant and monitor baby's weight and mom's milk supply. So in summary, when you think baby has a tight tongue, first make sure that it is not the mother's position, the baby's latch, the baby's suckling that needs adjustment or support. And if you do suspect a tight tongue, next step is to look at alternative positioning and jaw support to make the feed more comfortable for mom and baby, as well as help the baby be more effective with a deeper latch to remove the milk they need to grow as expected. And if positioning and support under the baby's chin is not enough, then you need to refer, and you're not an IBCLC, and you've done all that you can, the next step is to refer to a qualified lactation consultant or for specialized breastfeeding support and a systematic clinical observation and assessment of the mother-baby pair, including using a formal tongue assessment tool. Next step is to refer for body and mouth work, and then if body work alone doesn't improve the comfort and effectiveness of breastfeeding, only then do you refer to an ENT or a dentist for a diagnosis and a decision to treat. And then go back to the IBCLC for breastfeeding assistance, because the snip is not the thing that will fix everything. What the snip does is to allow for change to happen. And then take baby back for body work. So it takes a team. Multidisciplinary management and communication between lactation specialists and feeding therapists and surgeons and pediatricians are paramount for the best outcome for the family. So thank you for listening to this very long presentation. I hope that you have a better understanding of what tongue ties are, what some of the consequences are, how to spot it, how to cope with it using alternative positioning to help the mother and baby breastfeed more comfortably and effectively, keeping in mind other causes that might make it look like the baby has a tight tongue, and considerations around snipping or not. Thank you very much.